Good evening, everybody. I'm Bob Griffin. I'm the Dean of the College of Emergency Preparedness, Homeland Security, and Cybersecurity at the University of Albany. And thank you for attending our Monday night Zoom town hall on the COVID pandemic. This is the fourth, or I think the fifth town hall that we've held, and we appreciate all of your attendance. Just so you remember, you can enter questions and you can start asking your questions now in the question and answer tab at the bottom of your Zoom bar. We have a whole set of faculty and staff that are standing by to answer your questions as our presentations go on. As always, I'd like to thank our panelists, Dr. Chatterji, sorry, I practiced for that was from the economics department, who is going to speak a little bit about the economic impact of the pandemic and of social distancing. We also have the Dean of the School of Public Health, Dr. Holtgrave, who will give an update. And I'd like to thank both the Provost Kim and President Rodriguez for attending and listening in. I'd also like to recognize our friends, not only from the School of Public Health, School of Social Welfare, but also from Rockefeller School of Public Policy and other schools on campus, including the College of Arts and Sciences. A couple of quick updates that I'd like to give before I turn it over to Dr. Holtgrave. There's a couple of issues that I would like to raise for you. The first is recognition of the university's role and indeed the president's role as a key leader in studying the issues of health disparities. The governor has really taken this on as a major concern that has come out of the pandemic, and has asked the president to take the lead on looking at the whole issue of health disparities. And the president has brought together not only the College of Emergency Preparedness, but also School of Public Health, School of Social Welfare, and we're really starting to marshal the resources of the university in order to help the governor and the Department of Health in this situation. So there'll be a lot more information coming on this, but I think it's pretty exciting. It's also, I think, a testament to the amazing faculty and staff that we have on campus and the capacities that they bring. I'd also like to raise one issue for your consideration. The issue of American federalism. I'm sure a lot of you have been paying attention to what the governors have been doing, and you've noticed it's sort of been a patchwork of different policies and approaches that run the gamut from being particularly proactive in places like Washington State and California and New York and Illinois, somewhat less proactive in places like Florida. And then again, you start to see the tension with the president. And I think one of the more interesting subjects that I want everybody to keep an eye on is the issue of who is empowered to declare businesses open. And I think this is going to be one of what's going to be many really interesting questions of federalism, about where the power lies. My reading of the Constitution, understanding of federalism, would say that the power rests with the governors. That the president has tweeted otherwise. So I think it's going to be very, very interesting to watch what occurs there. A lot of tension still remains, I think, between the states and the federal government. And you're starting to see, I think, a very interesting a mix of relationships. I saw an article earlier about the West Coast governors and the East Coast governors making sure that they coordinate reopening. So that's going to be an interesting issue to watch. I'd like to now take an opportunity to turn the floor over to Dean Holtgrave and to give us an update on the COVID situation from his perspective and his work with the Department of Health. And Dean, I would be remiss if I didn't thank you on behalf of myself and the family for all of the work you're doing with the drug trials and as a senior mentor and advisor to the Department of Health.
Well, very kind of you. Thank you so much, Dean Griffin. It's a great pleasure to get a chance to collaborate with you and with the CEHC. It's always amazing. And wanted to thank, as you did, the president and the provost for joining us this evening as well, too. It's terrific. And to thank all the faculty, staff and students, not only of the School of Public Health and CEHC, but across the university. And before I dive into a quick update on where we're at with this pandemic, I wanted to take a moment to mention that we're joined this evening by a group of medical doctors and clinical researchers from Shanghai, China, who are listening in, and they've recently returned to their homes and hospitals after having been sent to Wuhan to support the COVID-19 response in that city. These colleagues are joining us as part of an initiative to build further on our collaborations between the School of Public Health and our partnerships in China to promote and exchange information and sharing of lessons learned between public health and healthcare professionals here in New York and in China. While our colleagues from China will simply be listening into our discussions this evening, we're looking forward to working with them on creating opportunities for all of us to hear from them directly and learn from their experiences in Wuhan in the weeks ahead, including during a possible upcoming participation in one of these town hall events. So let me please take this chance to thank these colleagues for joining us this evening and to thank them for the work that they have done and continue to do to help respond to this pandemic. We are truly honored that you are participating with us this evening. Thank you very much for joining us. So I wanted to give just a little epidemiological update and make a couple of other quick points, and then I'll turn it back to Dean Griffin. I think it's useful always as we start these out to go over a few of the epi statistics, and you all see these numbers online, of course, but I think it doesn't hurt to remind ourselves of just the stakes that we're talking about, especially because they change so much from week to week. Globally, we now are at 1.9 million cases and 118,000 deaths, sadly. In the United States, we're at about 568,000 cases and 23,000 deaths. And that's compared to the next country with the next most highest number of cases, Spain, which has 169,000 cases. So you see the big difference there. In New York State, we are now at about 195,000 cases and about 10,000 deaths. The positivity rate of the testing is still at about 40.8%. So still testing is more diagnostic in nature than assessing community-wide prevalence. And in New York City, we have about just under 107,000 cases and 7,300 deaths. The positivity rate of the testing is still just over 50%. So again, testing using more in a diagnostic setting or diagnostic sense. In Albany, we have about 499 cases and about 17 deaths so far. And again, if you're interested in more details about these statistics, COVID-19 tracker.health.ny.gov is a tremendously useful resource for understanding how the epidemic is unfolding here in New York State, City, Albany County, and all the counties throughout the state day by day. It's a great resource. Also, as Dean Griffin mentioned, I think there's two really important stories to just highlight this week. One is that regarding health disparities. We've known, I think, that health disparities play a critically important role in this pandemic, and that really has become an important point front and center as it needs to be this week. And this point was made in some articles in Politico and other outlets. And if we look at the fatality statistics in New York State, for Latinx communities, 34% of the COVID-19 fatalities, and this is in the city, I should say, are in Latinx communities, 34% of fatalities, and 29% of the population is Latinx. And so I think that's important that there's this disparity that we see. Even outside of New York City, about 14% of the fatalities are in Latinx communities and 12% of the population is Latinx. So again, we still see a disparity there, more pronounced in the city in New York. For African American communities, 22% of the population in New York City is Black. 28% of the fatalities are African American. So we see a larger disparity there. And then when we look at New York State, not in the city, 9% of the population is Black and 17% of the fatalities that are COVID related are African American. And so we see there a really pronounced disparity, not only in New York City, but outside of the city as well in the state. And these are clearly important disparities to address. They're even more pronounced in some other states, in Illinois, Indiana, and Louisiana. For instance, in Louisiana, 32% of the population is Black, and 70% of the COVID-related fatalities are Black. And so really, we have much work that needs to be done. And as Dean Griffin said earlier, we were all, I think, very proud this week when the governor turned to UAlbany and to President Havidan Rodriguez in particular to lead some work in these areas, not only to further document these disparities, but thinking about solutions to build health equity to address these disparities going forward. So I think this is a critically important part of the work that we all have to do. And I'm so pleased that UAlbany will be a key player in this as we go forward in partnership with the state government and the Department of Health. And the other theme I just wanted to highlight, and then I'll close, is this week there's been much discussion about, are we at a plateau yet or an apex in the pandemic? And if so, what can we do in terms of thinking about reopening? And I just wanted to say in New York State, over the 6 days from April 7th through the 12th, the number of deaths per day were 779, 799, 777, 783, 758, and 671 for a total of 4,567 deaths in those 6 days. That's an average of about 761 deaths per day, or about 32 an hour. And what that really means is at this juncture, for those 6 days, there was about one COVID-related death every 2 minutes in New York State from this novel coronavirus. So very sad statistics. And I think epidemiologically, what they're telling us, though, is that instead of a very sharp apex where it just hits a peak one day and then starts to decline the next, that by all the social distancing work that's been done, that we would have flattened the curve somewhat. And I think these deaths suggest over those 6 days at least, they kind of represent a flat mountaintop or a flat plateau. And hopefully that's an indication that we have indeed flattened the curve somewhat in New York State, which is would be very good news. But it also suggests that the decline on the other side might be a bit slow as well too. So as the governor was saying today, we maybe have reached this plateau, but we're not over it yet. We have to address how we will come down the other side of the mountain, if you will. And of course, that raises the discussion of reopening and how will we consider that, how will, and I don't mean just at the university, of course, but across the state, across the nation, around the globe. And three of the areas that we're involved in somewhat, Eli Rosenberg's doing very interesting work trying to calculate reproductive rates, which would be a key metric, I think, that would help guide when one could reopen. And if you do reopen, how do you guard against seeing second and third waves? And what kind of metrics do you use to know whether or not you've eased up too much, perhaps, and need to re-engage some of the social distancing kinds of interventions? Secondly, I think we're also engaged in some writing and some thought about the role of testing. CDC recently came out with some guidance about for critical infrastructure workers, how they might return to work. Interestingly, though, it didn't discuss the role of testing, and I think that's a really important issue to think about. I know that the governor often talks about the importance of testing, and more testing in thinking about returning to work, and I do think that's absolutely critical. And also today we were discussing in Stat News the importance of the size of the public health workforce. Some people have estimated that we need somewhere between 100 and 300,000 more public health workers just to do contact tracing related to this novel coronavirus in the U.S. And I think that's really true. I don't know exactly what the precise right number is, but we certainly need a major expansion of the public health workforce. And I think that all the work that's going on at UAlbany, not just in the School of Public Health, but across the university, is really poised to help make a contribution there as well. So let me stop and thank you again for joining in these town halls. And Dean Griffin, I'll turn it back to you.
Thank you, Dean Holtgrave. I really appreciate that. And I was remiss at the beginning not to remind everybody about sort of the simple fact that hate has no place here. Hate the virus, but love the people. There's enough pain and suffering, not only in New York, across this country, but across the globe right now. So please be tolerant of those around you and practice acts of kindness. It really makes a big difference. A couple of other points, and Dean Holtgrave, could you give that website one more time?
Absolutely. It's covid19tracker.health.ny.gov.
Perfect. Thank you so much. Say again.
I said apologies if I garbled it before, but thank you very much, Bob, for clarifying that. Thanks.
No worries. It's just so important. I wanted to say it again. A couple of other quick points that I wanted to add, and if I forgot this point, I wanted to recognize Dean Lynn Warner's, Dean of the School of Social Welfare's contribution to both the panel and the work that we're doing in the community, and all of what you're starting to see with this pandemic is how important and how interrelated all of our disciplines are, whether you're an economics major or in social welfare or public health or policy. It all comes together in a situation like this. I would also be remiss if I didn't recognize the technical brains behind this operation, and that's Matt Tyler. For those of you that know Matt, give him a shout out. He's been absolutely incredible, and I don't think that he gets enough credit for what he's done. So thank you, Matt, for all that you do. Now I'd like to ask Dr. Chatterji to make a few, take some time and let's talk about the economy. I know this is on everybody's mind. I mean, what's happening and you know, what does your perspective say about this pandemic? So thank you so much for being here.
All right, well, thank you very much. I'm very happy to be here. I hope everyone can hear me okay. So I'm talking about the economic impact of COVID-19, challenges and policy options. I'm Pinka Chatterji. I'm from the economics department at the University of Albany. So the goal of this short talk is we know we currently face a joint health and economic crisis on an unprecedented scale. So what do we know about the impact of COVID-19 and the public health response to it on the economy? So I thought it'd be most helpful if I focus on talking about results from academic papers from the economics literature that focus on the US experience that have been published in the last couple of weeks. So all the papers I'm talking about today have been published between February and April 2020. So just like in public health and economics, this is uncharted territory. So I'm looking forward to your questions, but I'm afraid there's a lot of uncertainty. I may not be able to give you a good answer to some of them. So this is an outline. I first wanted to talk about prior work in economics on pandemics. I want to talk about whether prior pandemics are relevant and introduce an economic framework to analyze the effects of the COVID-19 pandemic. So a lot of economists have been thinking about the economic impact in two phases. So phase one is where we are now. To save lives, by necessity, economic activity is being substantially reduced. So I'll talk a little bit about recent research on the effects of social distancing and stay-at-home orders on the economy. Will a COVID-19 recession differ from other prior economic downturns? And what economic policies can be used to aid recovery? Phase two, epidemic will be controlled by vaccines, treatment, and/or herd immunity, and containment measures will be less disruptive. We still know very little about that phase, so I'll just mention briefly a little bit about China's experience. So economic research on pandemics. So most economic research, or the pandemic that's most widely studied in economics, is what the great influenza pandemic in the early 1900s, which sometimes is called the Spanish flu. So recent research in economics suggests that this pandemic killed about 39 million people, about 2% of world population, which would translate to about 150 million people today. And this pandemic reduced real GDP per capita by about 6%. So can we take any lessons from this research to today? Well, this pandemic came in 3 waves, and we still don't know what the current pandemic will be like. But what was unusual about this pandemic compared to today's pandemic is the mortality rate was high among young, healthy people. So the economic impact is likely to be larger. But just to summarize some lessons for today from this pandemic, well, one interesting lesson was that, so there are several papers on the great influenza pandemic. Some of them use cross-country variation, and some of them use cross-state variation and cross-city variation in the United States. But these studies show that containment efforts were effective in reducing death rates, and also that containment efforts did not negatively affect economic recovery. So that's interesting for today because a lot of the containment efforts that were used are very similar to the ones that we're using today, social distancing. There's other papers that show that the pandemic had long-run effects on many economic outcomes that became apparent even 20 years later. So most economists are thinking about this pandemic, the great influenza pandemic in the early 1900s, as sort of an upper bound of the effects of COVID-19 on the economy. So there have been other pandemics more recent, and there are economics papers on those pandemics as well, but I won't talk about those because really that research is much more narrow than the research I just mentioned to you. So the COVID-19 pandemic is different from prior pandemics that have been modeled and studied empirically by economists, mainly because the countries most effective this time around are the largest economies of the world, accounting for, as a group, about 60% of GDP. So this graph is already outdated. The last two columns are already very outdated, showing the COVID cases and COVID deaths by country, because this chart comes from the end of February. But you can see here, the economies that contribute the most to world GDP, the US, China, Japan, Germany, the European countries, those are also the countries that have been hit the hardest by COVID-19 almost simultaneously. So it's likely to have a very large impact on the world economy. So as Dean Holtgrave was just talking about, right now the highest priority is flattening the disease curve. So this is a depiction of that that's being used in the economics literature. So on the vertical axis, you have the number of COVID-19 cases. On the horizontal axis, you have the time since the first case. The dotted line represents the healthcare system capacity, which in the short run is fixed. So we know that without any public health measures, the number of cases will greatly exceed the healthcare system capacity and lead to rationing of healthcare. So the idea is to flatten the curve or spread the cases over a longer period of time so our healthcare system capacity can accommodate the cases. So what's been noted in the economics literature is that if you can increase health system capacity, so imagine the dotted line moving upwards, that would allow us to both treat more people and relax containment policies, thus improving the economy without sacrificing public health. So this is flattening the disease curve. But in economics, what's being talked about is flattening the recession curve. So on this graph, on the vertical axis, we have the severity of the recession. So you can think of that as the reduction in growth that's caused by social distancing. And on the horizontal axis, we still have the time since the first case. So over time, as we engage in social distancing, by necessity, we reduce economic output. So that blue area under the curve, that shows you the economic output we're losing because people are home, they're not buying things, and people are at home and not working. But what happens in any economic system, there are so many interconnected networks that it's not just that blue area of output that we lose. There are all these negative spillovers throughout the economy, which cause us to lose even more output. And that's represented by the the area under the peach-colored curve. So the idea is that by using macroeconomic policies, we can reduce the impact of the recession. So nothing's recent anymore because everything's changing, but a fairly recent University of Chicago survey indicates that while most economists believe we will enter some sort of recessionary period, there's a lot of disagreement regarding whether it'll be sort of a sharp, quick recession or whether it'll take a long time for us to recover. So phase one, that's the phase we're living in right now. To save lives, economic activity is substantially reduced. So how does COVID-19 affect economic activity? So in economics, we use the aggregate demand, aggregate supply framework to explain fluctuations around the long-term trends in the economy. So on the vertical axis, we have the price level in the economy. On the horizontal axis, we have the quantity of output. So the aggregate demand curve represents the quantity of output demanded at different prices in the economy. The aggregate supply curve represents the amount of output firms are willing to produce and sell at different prices. So let's say it's February 29th and we're at point A, so we're in equilibrium. Well, what's happened in the month of March is that we have quarantine and stay-at-home orders in order to save lives. So what's happened directly is the aggregate demand curve has shifted to the left. So we've moved from point A to point B. So you can see what's happened is we have a reduction in the quantity of output. So a reduction in GDP. So the problem is that we don't just lose that output, that has a ripple effect throughout the economy. So you can imagine as firms are producing and selling less, they lay off their workers. So workers have less income. That also shifts the demand curve to the left. We have people fearful to leave their houses. We have heightened uncertainty about whether you're going to have your job tomorrow. So all that uncertainty also pushes the demand curve to the right. So ultimately, we end up in a situation where we're producing less than our natural level of output. So most prior downturns in the economy are driven by decreases in aggregate demand. And generally the policy response is to shift aggregate demand back to the right using fiscal and monetary policies. So in the case of COVID-19, we have a second shock going on at the same time. So aggregate supply is also shifting to the left at the same time that aggregate demand is shifting to the left. So part of that is because of the direct effects of COVID-19. Sadly, workers are dying, workers are sick, so they can't go to work to produce. Workers are not at work because they have caregiving roles at home. So those are all direct ways that the aggregate supply curve shifts to the left because of COVID-19. But we have the effects of the containment efforts themselves, and that's probably a more important effect in terms of magnitude. Just by design, the containment efforts prevent people from going to work. So that's shifting aggregate supply to the left as well. In addition, we have disruptions in supply chains, which increase the cost of inputs, also shifting aggregate supply to the left. So you can see that in this graph, it looks similar to the other graph in that the new equilibrium, we move from point A to point B, and again, we see a reduction in the quantity of output. So just to summarize, what's happening to the economy is that there are shocks to both aggregate supply and aggregate demand. So empirically, using data, it's difficult to separate out the effects of demand shocks and supply shocks. But in the end, the demand and supply shocks both predict a fall in output, which is one indicator of a recession if the fall in output persists. So what are the economic effects of social distancing? So social distancing means closing schools, universities, non-essential businesses, and having most working age people stay at home. So these public health policies cause unavoidable decreases in aggregate demand and aggregate supply. But they also have uneven effects on sectors of the economy. So what's tending to happen is that sectors in which the demand for the output is affected by stay-at-home orders are more affected. And effects also vary by the nature of the work. Some sectors allow for more telecommuting than other sectors. So a lot of the recent research has been focused on these two areas. So this is a very recent paper just published a few weeks ago. It's based on high-frequency financial transactions data that shows changes in spending among US consumers. So if you look at the very top panel, that represents the time period February 26th to March 10th, and it shows you changes in spending by category. And that during that time period, people were stockpiling. Household spending had increased by 50%. If you look at the middle panel, that represents March 11th to 17th, you see sharp drops in certain types of spending, especially public transit. There's still high levels of spending in food and beverages and food delivery. And then between March 18th and March 27th, you see very sharp drops in air travel and restaurants. So all of these effects were stronger in states that had mandated shelter in place prior to March 29th. So this just shows you the types of sectors that will be more impacted by COVID-19 and the associated public health restrictions to contain the disease. Certain types of, the whole stock market has been very jumpy, and there are a lot of graphs on the site that I didn't include, but certain types of stocks are especially affected. So here you see that the orange bars represent airline stocks. And what this graph is showing you is differences between the current period, COVID-19, the period just after 9/11, and the period of the global financial crisis in between 2007 and 2009. So you see here the effects on airline stock prices is similar to the 10 days after 9/11. So those stocks have been hit very hard by COVID-19. So another issue in which sectors will be affected by COVID-19, the effects are likely to be very uneven, is the percent of workers who can telecommute, and also whether or not different occupations are considered critical. So the worst hit areas are going to be places where people can't telecommute, and those occupations are not considered critical. So if you look at food preparation and serving, only 4% of people working in that area with that occupation can telecommute, and that's not considered a critical occupation. So the ability to telecommute and whether or not an industry is considered critical is very important in trying to understand which sectors of the economy will be impacted the most. So how would a COVID-19 recession compare to our most recent recession, the Great Recession of 2007 to 2009? Well, the causes of the Great Recession versus the COVID-19 recession are very different. And really what's happening now is, to save lives, we have to reduce aggregate demand. We have to shift that to the left, and same with aggregate supply. So we really can't use our conventional tools right now, because we can't shift aggregate demand to the right until people can go back to work and go back to shopping and things like that. And also COVID-19 probably will have larger effects on different sectors of the economy that are what are typical in a recession. Typically recessions will hit the construction industry, the manufacturing industry the hardest. And that's not going to be true for COVID-19. It's probably going to hit the hardest the more face-to-face service industries. So I know the question is, how long can production shut down without causing a recession of a massive magnitude? So it's hard to estimate, but there have been some estimates that if public health measures shut down the economy, let's say by 50% in 1 month, like let's say 50% in March, and maybe 25% in April, that would be like a very sharp but short reduction in activity. And then let's say we completely return to baseline, this would reduce US GDP growth by about 6.5% compared to the previous year. So just to give you some context, the Great Recession, during that time period, real GDP growth fell by 4.3%. So that's really a massive reduction in GDP growth. If you extended it another month, another 25%, it'll be a reduction in US GDP growth by about 10%. So during the peak of the Great Recession, the unemployment rate was 10%, but COVID-19 is leading to maybe 50% of workers not working. And there's one estimate of what the current unemployment rate is going to be this quarter, and it's based on a lot of assumptions, but it's looking to be about 35%. But I think what matters is the duration of that unemployment. So it's not just the current unemployment rate. So COVID-19, I mentioned it's going to have different effects on different sectors of the economy. One such sector is the healthcare sector. So typically the healthcare sector is relatively sheltered from the business cycle, because people visit the doctor, regardless of the business cycle in a lot of cases, and also because many people have insurance coverage. But in the current crisis, healthcare providers are seeing a plunge in healthcare services usage for a lot of different reasons, but one primary reason is because of social distancing. So that's going to be something that comes out of this that will be different. In Michigan, recent data shows the second largest source of unemployment claims is actually coming from the healthcare sector. Restaurants and bars are first. So this article actually just came out today. So there's some new estimates of the effects of COVID-19 on small firms. So this is data that comes from a survey of 5,800 firms with fewer than 500 workers. And most of these firms have fewer than 5 workers. The survey was conducted on March 26th. And you can see, if you look at the very first column, it's the percent of firms that are currently closed. So about 52% of retailers, all retailers except for grocery, are currently closed. And you see the uneven impact. Tourism and lodging is hit very hard. Healthcare, while banking and finance has not been hit as hard. So I'll end with this slide, and maybe we can talk about policy options during the discussion. But when we think about policy options, it's important to remember that if you take a bird's eye view of the economy is this interconnected web. So when one portion of the web is hit by COVID-19, it reverberates in all the other portions of the economy. So for example, the players in the economy, the households, the government, the business, and then we have the rest of the world in the financial sector. So for example, if businesses lay off workers, if you look at the bottom arrow, well then households have less money to spend, and that reduces consumer spending, which goes back to businesses. When households have less money to spend, they have less money to spend on imports. That goes to the rest of the world, they have less money to pay for exports. When households have less money to spend, they may default on their loans. That affects the financial sector. They may be less willing to lend money because people are defaulting on their loans. So when we think about policy responses, we have to think about this complicated web and all the reverberations through the whole economy. So I had a couple more slides on policy options, but I think I'll stop there since I think I've run out of time. So I'll close this.
Great, thank you so much. I'm going to put you on the spot if you don't mind. If you could give one piece of advice to the Fed, what would you recommend? Yep. Wait, hold on. You're muted.
Am I okay now?
Perfect.
Okay. I guess, and I'm actually borrowing this from the papers that I've been reading. I think the message is go big. I mean, do big things. You know, don't hold back now. Don't worry about taking on debt to fund this disaster. That's the message that I think is coming across from all the macroeconomics literature that I've been reading. So don't hold back, I think, is the central message I would give. It's really a disaster. I mean, it's not a stimulus. So we need to sort of keep the lights on in the economy until we can get through this.
Great. Thank you so much for that, and just huge props for actually being able to pull an article out that was just published today. So thank you so much for doing that. Now we're going to get into our questions and answer period, and this is where I turn our town hall over to our question guru. That's Dr. Goodall, who is the Vice Dean of the College of Emergency Preparedness, Homeland Security, Cybersecurity. Honestly, the brains behind the operations. So, Dr. Goodall, if you could start to ask the panelists questions, that'd be great.
Sure. I will just point out that some questions have been answered, and so you can see the written answers to those, but I also have some that our panelists are going to talk about. So, Dean Holtgrave, we'll start with you. 2 questions regarding testing. When you say testing is basically being used as diagnostic, what does that suggest about the degree of the undercounting, both for the disease and the death rate? Do you want that one first, and then I'll come to number 2?
Let's take both at the same time.
Okay, and number 2, what will it take for us to get testing done widely enough to monitor and assess to make it safe to return to work and stay there? Is it feasible to do that testing?
Great. Thank you very much. Those are great questions. And also, before I answer them, I just wanted to add to Dean Griffin's thanks. Dr. Chatterji, I learned so much from your presentation. Thank you so much for joining us this evening. It was terrific. Thank you very much. I think these questions about testing are really important. I think right now, since we don't have yet a treatment and a vaccine, although both are being tested as we speak, physical distancing and testing are the 2 main ways we have to try and address this pandemic. And I think the first, just to elaborate a little bit on what we mean by using tests in a diagnostic manner, especially in New York City, we see this very clearly. The health department in New York City has really put out a plea that only CDC priority 1 testing should be done. And what that really means is tests are really reserved for persons who are healthcare workers or persons who are symptomatic for COVID-19 and who are hospitalized or in the process of being hospitalized. Because they don't have enough PPE for the healthcare providers, and there's limitations on the testing supplies, including swabs and so on. They're really discouraging testing. There we go. Does that sound better? I'll start over. I'm not sure where we can go. I just got a message on the screen that I was muted by that. Let's see, I was just muted by the home station. Jen, are you trying to tell me something?
If Dr. Holtgrave's head starts to spin around and he starts spewing pea soup, then we know exactly what happened to his system. I'm sorry, you were you sounded like you became possessed. Why don't we try it one more time and see if we can get a little clearer.
Hey, that's good. Let's try one more time. I'll start at the top. So let's see if that works better. Let me just say, Bob, is that okay? Can I hear my better now?
I'm hearing a lot of feedback right now.
Do you want to go on to a question from somebody else, and I'll see if I can address the symptom a little bit? Let's start that.
Perfect.
Sure, we can do that. So, Dean Griffin, touching on what you mentioned earlier, how has the growing rift between the federal and state governments impeded the containment, treatment, and management of the outbreak?
Well, it's impeded in several different ways. One is that I felt that the federal government was too slow to react to initial reports of the virus and the potential spread of the pandemic. I certainly wish that we had been looking more closely at our pandemic stockpiles, including our respirators and our medical capabilities. I also think it was a failure on behalf of the federal government not to try to coordinate better among and between the states. It doesn't do North Carolina any good to put in really strict social distancing policies if South Carolina or Georgia or Florida is not going to do that. And you saw that. You saw some governors decide that spring break or Mardi Gras was more important than dealing with the crisis. At its heart, while the governors are still empowered under our Constitution, that the federal government has a huge role to play here because of the fact that this is a truly a national challenge. In fact, for the first time in our history, all 50 states have a declared state of emergency at the same time. So to answer the question, I think it impacted logistics. I think it impacted the ability of the states to actually get needed supplies down to the local level, and you see that with ordering, where I think the governor was our governor, Governor Cuomo, was very eloquent in talking about asking for or trying to purchase supplies and personal protective equipment, only to be outbid by California, who was then outbid by the federal government, and that's the type of coordination that I think would have made this better. I'll also tell you that I don't believe that this is necessarily a partisan divide, although I think if you read Twitter that you feel that it's the president versus Democratic governors. I think there's as much tension with Republican governors, and I think a lot of Republican governors have done an amazing job. So if you look at, if I could point to DeWine in Ohio, I think he's done a really remarkable job. So I do think that the current state of affairs has led to a level of discoordination which negatively impacted the nation's ability to initially respond. And pandemics, this is one of these, it's an incredibly hard call, because if you make the call quickly and then if it works and you don't see a lot of people sick, then people say, oh my God, you shut down the economy for no reason. But at the same time, if you're too slow, that graph that was shown just shows you what the potential impact is. It also shows that I think the power of the governors in ways that we haven't seen for many, many generations. Do we want to try, Dean Holtgrave, do you want to try your communications again?
Let's try one more time. Let's see, is that any better?
No, you're sounding still a little bit rough. Is there, Dr. Goodall, why don't we go to some other questions and we can see if we can patch the good Dean in a different way.
Sure. Dr. Chatterji, I think the stress on people's health and the healthcare system, as reflected on the graph you showed about health provision, doesn't reflect how much people are refraining from using the health system who should, whether for COVID-19 cases, refusal to be hospitalized for other maladies, deferral of necessary treatment that can be deferred for a time, etc. So the relationship between use and availability misses this. Can you comment on this?
Can you hear me okay? You can hear me, right? Yeah, I think that's a great point. And right now, we can't differentiate between people who, for example, should be having their blood pressure checked every week and are not going to the doctor, and we'll see that turn up later as an emergency room visit. And right now, we can't observe those outcomes because they'll happen later on. So no, that point is well taken. And I guess I wasn't trying to say that people are not visiting the doctor and that has no effects. All we can measure now is people are visiting the doctor a lot less. Another thing I should mention is that telemedicine is really ramping up rapidly. That's one development that's happened because of COVID-19. And I am actually looking at this with some data with a colleague in economics, and we can't differentiate telemedicine versus regular face-to-face office visits, but that's definitely impacting things as well. I think probably a lot of conditions can be managed over telemedicine, and we're starting to see more and more of that. So in conclusion, no, I'm not trying to say that that the visits that are not happening because of social distancing shouldn't be happening. I think we'll be able to measure those effects later on when we have more data.
If I could just jump in, I think it's an excellent point, and I think one of the things that we're going to have to watch is what will be the long-term impact on how we operate as a society after this. I mean, have we fundamentally changed the way we're going to approach virtual meetings or telemedicine? I think is a really good example. All of which are going to have enormous impacts not only on the economy but also on future employment opportunities, and where the new markets are, and I think that's one of the things that we all need to watch and make sure that we're ahead of the curve on that as well.
Thank you. Dr. Chatterji, if we can come back to you, will we see an end to stock buybacks when this is all said and done?
I don't know. There's so much volatility right now in the stock market. I mean, things are so unpredictable that it's very hard to say. I mean, really, without knowing more about what's going to, the public health, the virus itself, the public health response, and the economy are so interlinked that it's impossible to say anything about the economy or the stock market without knowing more about what's going to happen with the public health efforts, how effective they're going to be, whether we're going to have the confidence to go back into the market. That's all sort of a big question mark now.
Thank you. If high volumes of unemployed are coming from the healthcare sector, does this present a new workforce training opportunity for frontline clinical training programs to shift these workers to the front lines or epistatistics temporary needs?
Was that towards me? Oh,
you can take the first jump at it, and
sure.
then I'll jump in and hope that Dean Holtgrave gets back on quickly.
I guess my view would be that I think this is a temporary thing. I mean, I don't think that I think once people feel, I mean, right now what's happening in a lot of doctors' offices are telling you to stay home, right? I mean, so a lot of this coming from that. Another thing that's happening, people are losing their jobs and they no longer have health insurance coverage. So that's preventing them from going to see the doctor. People have a lot of fear about going to see the doctor. So some of those things I think will change in the coming weeks. I mean, I don't think that it's going to be a permanent thing with the shock to healthcare demand.
Yeah, I do think there's an opportunity here as well, though. When you start to think about the issue of personal protective equipment for healthcare workers, and I'd be remiss if I didn't recognize the work that Dr. Goodall has been doing, along with other members of CEHC and the College of Applied Engineering, doing 3D printing. So you're actually, this crisis is actually starting to change how we're introducing technology into fields that may have been much more reluctant to use them in the past. So while I think that the response from the doctor was spot on, I also do think that there are opportunities to think differently about what the economy is going to do. So again, technologies like 3D printing. I also expect to see more muscle to go into things like UAV deliveries so that we can start to automate delivery systems, because we're starting to see how fragile our systems are. And we really need to make sure that they're more robust in order to be able to get necessarily and essential supplies to people, particularly during a crisis like this. So it's both a challenge and an opportunity. And while I believe it's going to bounce back, I do think it's going to bounce back not quite in the same shape it was. It will be different in certain areas.
I just want to confirm that Dean Holtgrave is now on the phone.
I am. Can you hear me, Jen?
Yes, excellent.
Thank you.
Thank you.
Welcome back.
Thank you, and my apologies.
No problem. So question for you. It has been suggested by certain models that the peak of infections/deaths will hit the capital region later, as late as late May. What are your thoughts about this particular prediction?
Great, thank you. And again, apologies to all the participants for the difficulty with Wi-Fi here this evening. I'm very, very sorry about that. So maybe just to finish the questions we had earlier about testing, and then go on to the peak in late May. Just the earlier question about diagnostic testing. So what we really mean by that is, in New York City, for instance, the testing has really been reserved for persons who are healthcare workers or persons who are symptomatic and hospitalized or about to be hospitalized. And of course, that is the number one priority. But at the same time, if the tests are very much tightly reserved for those communities, then we really don't have a good sense of what's the total number of cases and what's the total number of community-wide infections that there might be. And so that really means we need to do much more widespread testing, things like community sero surveys and different approaches to doing surveillance work that let us get a better sense of what's really the incidence rate looking like at the community level. So that's an important next wave of testing that will happen. Also, I would say in terms of whether testing will be available in the scale needed in terms of return to work, I think a really important turn of events over the next week or two is going to have to be to see the rapid tests, which are now available, but more limited in terms of the how widespread they are in production and availability. We'll need to see much more widespread availability of rapid testing results out there. And I think that will help us be able to say when someone is preparing to return to work, that we can get a sense not only whether or not they have symptoms that look like COVID-19 or have a fever, but actually have a rapid test that's done. And that'll be really important. Even also helpful will be looking at antibody tests, which will give us a sense whether someone might have had COVID-19 but has cleared that infection. And so I think that's an area that's getting a lot of attention right now, but needs to be scaled up quite rapidly as we talk about return to work issues. And then finally, the most recent question about peak here in the capital region in late May. I think it could perhaps be a bit earlier than that. I think one of the things that we will see possibly in the capital region is that testing was a little bit more widespread, but then became more limited in terms of the number of tests that were available. And Dr. Whalen, the Great Health Commissioner in Albany County, said in a number of press conferences that there was a time at which they had to do something like New York City and limit the tests to persons who were healthcare workers or persons who were symptomatic and hospitalized. That's becoming much more widespread, including with the great drive-through testing that's available now in the parking lot at UAlbany. And I think what we will see is that as this testing starts to get more widespread in the capital region, you'll see a temporary period, hopefully a temporary period, where you'll have more numbers of cases as testing gets more widespread. But that's kind of catching up a little bit, if you will, for cases that are out there but not yet diagnosed. And I think as we look at lots of different kinds of models, what we have seen in terms of the peak in deaths that I was talking about for New York State certainly could come at a bit different time for other parts of the states. And this is one of the other questions that was raised in the Q&A as well, too. Certainly in the capital region and Rensselaer County and so on, we may see the peak in terms of deaths flattening a little bit further out in a little bit different ways over time. But I think we'll have to wait and see. But I think the peak in the capital region could come a little bit earlier than that model that suggests late May. But time will tell, of course.
Dean Holtgrave, a couple of weeks ago, we got a really excellent question about herd immunity. Is there any additional information, or is it still too early to sort of have a better sense of herd immunity for the virus?
Yeah, well, it's a great question, Bob. And I think we still don't have a final answer on that. I think that the discussions that are going on right now First, there was a theory by some in California that perhaps this novel virus was introduced in California earlier than people had thought, and that one of the reasons why the peak was not as high so far in California was a function of herd immunity. There has been some disagreement with that because of different points of view about the timing of when the virus could have been introduced in California. I think the other thing is, even with what we're seeing in New York State at the peak now of terms of deaths, this kind of flat plateau, one of the things that people are trying to actively calculate is working backward. What does that mean in terms of number of cases in the population at large? And we don't know that number for sure, but Debbie Birx in the White House press conferences will say something like the attack rate for New York City is about 14 in 1,000. So that would imply roughly kind of a 1.4% prevalence. And when we think about herd immunity, we often think about maybe 50 or 60 or more percent of a population having an experience with a virus and resolving it and then protecting other parts of the population. And I think even in a hard-hit area like New York State, as difficult as it has been, thankfully the percentage of the population that has been infected with coronavirus is probably not nearly as high as one might normally think is necessary to introduce herd immunity. So it's an area of a lot of discussion and some debate. And thanks for raising it, Bob, because I think this is something we need to come back to every week or two and continue the discussion. And that's one of the reasons I like these town halls. It lets us continue to talk about what do we think as opposed to what do we know from week to week.
Yeah, true. And this is such an evolving situation that even what we thought we knew a month ago is in some respects different. Dr. Goodall, right. The next question.
Sure. This goes to anyone. What will the economy look like for next year? Some people are getting their $1,200 checks. What will that do for the economy next year?
Dr. Chatterji, would like to take that?
Sure. Well, I guess right now the CARES package that's being implemented, that's really like a relief package. It's not really a stimulus package. So that's kind of intended just to cover people so they can just get through the next couple of months. What will things look like next year? I mean, again, I hate to go back to this again, but it really depends on, I mean, the spread of the virus itself, the public health efforts to contain it, how effective they are. Because all of those things affect consumer confidence. I mean, if consumers feel like it's safe to go out and spend again, and they feel like if there are multiple waves of this epidemic, the government has it under control and, they can get back to work, I think it'll be a really different story than if they feel like containment and the public health infrastructure is not there.
Yeah, and I think that there's going to have to be more federal recovery packages like we've seen. I would imagine that the states and local governments are going to need federal assistance. I also think this is an opportunity to start to rethink the opportunities to put in an omnibus package for infrastructure as a way of starting to sort of jumpstart large elements of the economy as well. I think what makes the question even a little more difficult is the sort of unknowns what happens in November with the election. I think that will also play a major role in what occurs with the economy. So it's something we absolutely will be watching.
We have a couple of questions about quarantine. And specifically, do you think there needs to be a quarantine zone like we saw in New Rochelle?
Thanks. I'm happy to start with that question. I think the quarantine zone that was introduced, or I think it was called a containment zone at the outset around New Rochelle, was really the first that was put in place because as the epidemic unfolded in New York State, Westchester County, where New Rochelle is located, was really the first area where there seemed to be ongoing community transmission. And that was really the first response from the state to say there would be a mile across containment zone around New Rochelle. And I think that actually the terms, as I understand it, of what that meant is now quite similar to the New York on pause order that's across the state, because I think early on there was a sense that with that containment zone around New Rochelle, that it meant that people couldn't go in and couldn't go out, but that wasn't really the case. People could move in and could move out of that 1 mile zone, but it really meant that that was the first area in the state where the businesses were asked to shut down, the schools were asked to shut down, people were asked not to congregate in groups. And as I think back to what did that mean, what were the elements that were part of that containment, it's really quite similar to the elements of New York on pause. So in many ways, I think the answer to the question, at least from my point of view, is that the whole state is now kind of in what had then been called a containment zone and now is called New York on pause. So I think all of those elements are really applying to everybody across the state at this point. Thanks, Jen.
Moving forward, though, as an emergency manager, I'd be saying that if in the future I saw a similar type of outbreak, I certainly would move faster in order to set up a more secure zone as a way of trying to be more proactive in nipping off the spread of a virus like this. So I do think a lot of different types of planning are going to have to occur at the federal level between HHS, Health and Human Services, Homeland Security, and probably Department of Justice, and certainly I think their counterparts at the state and local governments will also have to be rethinking their emergency plans and procedures. So I do think moving forward, you're going to see a much more aggressive stance than we saw with this event. I think we have time for one more question, Dr. Goodall.
So another question, why aren't college freshmen and sophomores eligible for the $1,200 package?
I actually don't know the answer to that question. I didn't realize that they were not eligible for the stimulus. Does anybody else know? I didn't.
I'd assume that if you had paid taxes in the past that you were eligible. I don't know, but I'll tell you what, we will get an answer for next week. And if you come back next week at the same bat time, same bat channel, we will have an answer for that. In fact, I will start with that next week. That was an excellent question. We'll dig into that.
Okay, so I think a couple of different answers just came in for that one, but we will, like you said, investigate and come back. Dr. Holtgrave, how would you explain such a discrepancy in New York State needs estimate of 30,000 in ventilators and 140,000 in hospital beds in the current situation that shows much lower need now, which is excellent news?
Great. No, it's a terrific question. So I think one of the slides that's really quite welcome news, as you're saying, that the governor uses in his press conferences is if you look at models, the one of which was from Columbia University, had suggested early on that there was going to be a need for something like 110 to 140,000 hospital beds in New York State focused on COVID-19. And then McKinsey and Associates had a model that put that somewhere more between like 55,000 at the low estimate and roughly 100, 110 kind of at the upper estimate. And the earliest estimates were the higher ones. And then over time, there got to be the use of the IHME model out of the University of Washington, which brought the estimate in at a lower number than that. And now that we see the actual experience on the ground, it looks like it's a number that's substantially even lower than that when we look at hospitalizations and therefore ICU needs and ventilator needs. And I think the main thing that I take away from this is when I've done a fair amount of mathematical modeling in my career as well, but I kind of divide models into two big classes. One is models where you're really got a very uncertain circumstance and you're trying to use the best methods you can to estimate where we're going to be in the future, but there's not a lot of guidance on what the input parameters are. And I think that's kind of what we found ourselves with the earliest use of like the Imperial College model, the Columbia model, maybe some of the McKinsey model early on. And then there's another class of models, which is very much like this IHME model out of Washington, where you start to collect enough data and you're really kind of more in the curve fitting exercises than you are with kind of modeling with lots of uncertain parameters. So a lot of what IHME starts to do is to say, let's observe deaths, let's observe hospitalizations over time, and then based on the nature of that curve, what do we think is going to happen in the future based on what we know about natural history of disease? And just over my career in HIV, I tend to do more of that latter kind of thing, where I've got a few statistics, I've got a few numbers, and I try and stack them up in different ways to see what they tell me. So I take a few things that I know with some reasonable amount of certainty and see what they tell me. And that's a little bit more like the IHME model, and then what now is happening with the projections that you see in the governor's press conference, where they take what's actually been observed by deaths and hospitalizations and ventilator uses and their intubations and so on, and then plot the kind of 3-day averages going forward and then doing a bit of curve fitting after that. So I think it's better to use the first kind of model than nothing at all, because it gives us a better sense of what might we be in store for. But I think it's always important in these models to recognize what's the uncertainty. And I always worry when early on, if you don't have a lot of good guidance for your input parameters, if you don't see a lot of estimates of what the uncertainty is, and you don't have a lot of kind of error bars, if you will, around your estimates of the model. And then over time, as you start to collect data, like on fatalities and hospitalizations, and you can move to more kind of curve fitting based on observed data, I think you can quickly get to those estimations better. The other thing is, I think that we are in uncharted territory in terms of this level of societal stay-at-home kind of orders. And early on, I think there was not much of a sense of what might that do to the epidemic entirely, and how much would people go along with it? How much would people sort of stay in their houses and not go out? And so we're learning about that at the same time. I think also, too, there was a sense that we had to pay a lot of attention to that, because as people started to see what was happening, as hospitals were filling up, as ICUs were starting to fill up, as there's a need for ventilators, people realized that they had a responsibility to play, and that was to stay at home and do their part that way. And so I think those are a few of the factors that lead into this now more fortunate circumstance, where the need for the hospitalization resources and ventilators in particular is lower than might have been first thought. And it kind of reminds me of something I said, I think last week, that Dr. Fauci has said, even if models estimated there were going to be 100,000 deaths in the United States, we might have to prepare for that, but we don't have to be prepared to accept that. And I think that people are really always pushing on what we can do with physical distancing and testing and other kinds of strategies to get the numbers down as low as we possibly can. So those are a couple of thoughts.
Well, I'm gonna call a wrap now. We're a little bit over time. I appreciate everybody who is on. We still have some questions that we didn't get to. We'll get to next week. I'd like to thank Dr. Chatterji. Thank you so much for being here. It was excellent. I'd love to invite you to come back. And I thank you and the Department of Economics and certainly the College of Arts and Sciences for being a great partner with us. As always, Dean Holtgrave, you are a credit to your profession and the university. Thank you so much for everything that you've done. And for everybody at home, we're doing wonderful. And keep the faith, and part of what we do as a community is this type of town hall, and you being informed makes a huge difference. On behalf of President Rodriguez and Provost Kim, Dean Bob Griffin, and I want to wish you all a very safe week, and I hope you return next Monday at 7 o'clock for another edition of our town hall. Everybody, peace and out.